Good evening, everyone, and thank you for joining us tonight for Illinois Bone and Joint Institute's 57th virtual YMCA Education Series program with the North Suburban YMCA. My name is Karen Brownlee, and I am a personal trainer and the adult program coordinator at the NSYMCA in Northbrook, Illinois. This evening's presentation, entitled Shoulder Injuries and Disorders, is being recorded so that you will be able to revisit it again. Please feel free to tell your family and friends about it so that they too can view it once it is posted on the IBJI and NSYMCA websites. The shoulder is one of the most intricate and flexible joints in our bodies, and even everyday tasks, such as typing and eating, require movement and use of our shoulders. In fact, something as simple and necessary as sleeping can be seriously impacted by shoulder pain. Shoulder injuries and disorders are widespread and include dislocations, instability, impingement syndrome, rotator cuff tears, frozen shoulder, and more. These conditions can result from trauma, sports injuries, and chronic wear and tear, particularly from activities or occupations that involve repetitive overhead movements. Tonight, IBJI's Mark Breslow, MD, will walk us through shoulder injuries and disorders, their symptoms and causes, and the treatments available to alleviate discomfort and promote healing. Dr. Breslow is a board-certified orthopedic surgeon, fellowship trained in sports medicine and arthroscopy. He has been in practice since 2001 and with IBJI since 2007. Dr. Breslow is also on the National Board of Medical Examiners. Dr. Breslow treats athletes of all ages, from children to the elderly, and specializes in treating both knee and shoulder problems. Tonight, he'll focus on the shoulder joint. One of the things Dr. Breslow loves most about being able to practice orthopedics is that he gets to fix things and is actually able to improve people's lives. He enjoys being a team captain on his patients' treatment teams, working with physical and occupational therapists, medical assistants, athletic trainers, and the most important part of the team, the patient. A huge part of Dr. Breslow's practice is working with his patients to get them on board to understand what the problem is, what the team is doing, how the team will work with them to manage care, what their role is as the patient, and finally, the importance of their participation in the process. Dr. Breslow believes that communicating with his patients and their families and educating them about their condition and recommended treatment options leads to the best outcomes. One of the things Dr. Breslow finds fortunate about working at Illinois Bone and Joint Institute is that IBJI covers all aspects of musculoskeletal care. They are able to provide a wealth of knowledge, and he gets to be part of a group that delivers a huge spectrum of care. He says that his team's success stories are, once treatment is complete, never seeing their patients again in the clinic. Ultimately, Dr. Breslow is most happy when he sees his patients out on the street as opposed to back in the office. Dr. Breslow received his medical doctorate from Rush University College of Medicine, fulfilled his general surgery internship at New York University Medical Center, completed his residency in orthopedic surgery at NYC Hospital for Joint Diseases, not just disease, Orthopedic Institute, and pursued his fellowships in sports medicine and arthroscopy at Temple University. A staunch advocate of returning his patients to their pre-injury level of activity and getting them back to their lives as effectively and as safely as possible, Dr. Breslow is the orthopedic team physician at both Notre Dame High School in Niles and Niles West High School in Skokie, Illinois. We're lucky to have him with us tonight because I imagine he's a pretty busy doctor on Friday nights during football season. In addition to all of this, Dr. Breslow is an assistant professor in the Department of Orthopedics at the University of Illinois Medical Center at Chicago. During Dr. Breslow's presentation this evening, you might find that you have questions for him, which he will be happy to address at the end of the program. Simply type your questions into the question section on your screen, and I will receive them and relay them to Dr. Breslow immediately following his presentation. I do ask that you please keep your questions general, as he will not be able to address individual concerns without individual consultation. If you do have self-specific questions, please contact Dr. Breslow via one of the options that will be listed on the slide shown during the Q&A portion at the end of our program tonight. One last thing before I turn the evening over to Dr. Breslow. Please mark your calendar for our next IBJI and NSYMCA Education Series program on Tuesday, October 29th at 7 p.m. Dr. Jeremy Orion will discuss advancements in knee replacement. Thank you again for joining us tonight, and thank you, Dr. Mark Breslow, for your time and effort in putting together this program to discuss shoulder injuries and disorders with us. Dr. Breslow, please take it from here.
Wow, Karen.
I told you it'd be long.
That was amazing. I'm telling you, I wish my mom was here. I mean, you make me sound so fantastic. It's unbelievable.
We think
So
you are.
I just appreciate that introduction. It was really wonderful. I'm excited to see how many people have joined us tonight for this talk. I hope it enlightens you all on some very common problems that we all experience in the shoulder. Unfortunately, it's a very common problem to have as we get older. Our shoulders can be a culprit for a lot of the aches and pains we have. So with that said, we'll go ahead and get things started here. I don't know if my camera just came up, but I'll do this. Here we go. So as she said, I began at IBGI in the fall of 2007. Before that, I was at DuPage Medical Group out in DuPage County. I work mostly out of Morton Grove and Des Plaines currently. I have training in general orthopedic surgery, which is musculoskeletal system from really the neck to the toes. We don't deal with the jaw and the skull at all. And I have a subspecialty in sports medicine arthroscopy because I really like doing outpatient surgery dealing with athletes. And most of my patients go home the same day after the operations that I do. I practice general orthopedics, as I said, but I really have a primary interest in shoulder and knee. But I see most things that walk in the door, back, ankles, hips, shoulders, wrists, fingers, toes. So I can manage most things, but my true interest is the shoulder and the knee. So she's mentioned in the introduction, there's been a huge increase in activity level of today's population. Pickleball is super hot right now. The nice thing about it is all age groups from little kids to the elderly can participate. And with this increased activity, there's a lot more injuries. The median age has increased with baby boomers. People are staying active longer, which is wonderful. That also exposes us to more injuries. There's increase in females and older population in our labor force, also a culprit for more shoulder injuries that I see in the office. The shoulder, as she said, is really a wonderful thing. It really has the largest range of motion of all the joints in the body. The hip, on the other hand, is a relatively stiff joint. And the reason for that is we don't need to get our foot the places we need to get our hands to grab things, to maneuver and manipulate objects in our world. And because of the fact that our shoulder has such a large range of motion and it's involved in so many of our hobbies, work activities, sports, it places the shoulder at risk. And that can be due to trauma or just overuse, just repetitive activities on the athletic field in the workplace can cause shoulder symptoms. So what we're going to discuss today is the management of these shoulders, aches, and pains. And as we get older, a lot of it's related to just muscle and tendon strains. Fortunately, there's not a lot of fractures of the shoulder. There's not as much arthritis of the shoulder. A lot of these aches and pains are really due to tendon and muscle problems that occur. And realize that you'll talk to different orthopedic surgeons depending on where they were trained, the age that they trained at, how current they are, how up to date they are. They may have little different opinions, little different ways of managing these. So really ask those doctors about those opinions, why they're recommending a certain treatment plan when your friend says they're doing something totally different. So communication is really the key. We're going to go through the anatomy. Pathology is actually another name of saying disease. The history, how we got there in the first place, why we went to the doctor, our physical exam, which is how I physically evaluate the patient, imaging, treatment, returning to activities, and how we prevent these shoulder problems. So we'll start with the anatomy. And the bones are really the building block. Orthopedic doctors are specialists of the bones, the musculoskeletal system. Without this set of bones, we would be a pile of soft tissue on the ground. It's really our erector set. It holds all our soft tissues and other organs up in place. They provide structure, they provide support. And in the shoulder, there's three bones that make up our shoulder joint. There's the humerus bone, which forms the ball of the shoulder, and the upper arm. That's the upper arm bone from the elbow to the shoulder is our humerus. The scapula, some people call it the wing, is our shoulder blade in the back of the shoulder behind the rib cage. And then the clavicle, better known as the collarbone. So these are the three bones that make up our shoulder joint. Then on top of those, we throw the superficial muscles, and these are the famous muscles, the ones that we can really look at. They give us aesthetic beauty to the human body. They're the ones that we work out in the gym, and these move the bones in space by pulling on tendons. So again, we fire our muscles. Those tendons are attached to the bone that help move our arm in space. The famous muscles here are the deltoid, the pectoralis major in the front, trapezius, which forms part of our shoulder, the trap, and our latissimus, which is in the back of our upper back. These are the muscles, again, we can see, we can work out in the gym. They're more famous, and they're ones that fortunately are rarely, if ever, injured. The most things that might happen is they get bruised. The trapezius, the deltoid, the lat are ones that are almost never injured. The pec rarely, mostly with bench pressing, is the one that gets injured and can get pulled off the bone. But these, again, are the famous ones, but the ones that are less significant to me because there's not a lot of damage that occurs to them that I have to manage in my office. Ligaments connect bone to bone. versus tendons that connect muscles to bones. So the rotator cuff that we'll talk about in a second is attached to the bones through those tendons. We hear all the time about the rotator cuff. A lot of patients come and say it's with the rotator cuff. It's actually a cuff of tissue. And what that is there's 4 muscles that attach to that shoulder blade. Those muscles send tendons to grab onto the ball. So again, the muscles attach to the shoulder blade and they won't go ahead and transfer their forces by tendon to the ball of the shoulder. And the way we describe those muscles is based on their location along that shoulder blade or scapula. We see on the left side there is the front picture. The one on the right is the posterior or rear picture of that shoulder blade. And there's something that bone sits on the right shoulder. There's a spine of the scapula. And so our rotator cuff muscles are named in relation to that spine. So below or in front of the shoulder blade is the sub or below scapularis. Behind are the infra and supraspinatus muscles and tendon units. Those are named in relation to the scapular spine or that bone that sits between them. So supra above the spine of the scapula, infra below. And those 4 muscles send tendons to grab onto the ball, and those tendons form a cuff around the ball and socket joint. Therefore, they're called our rotator cuff. Then we have other supporting soft tissues. There's something called cartilage. Cartilage covers the surface of our joints, the surface of the ball and surface of the socket, but also forms a ring around that socket. So in this one picture here, we've taken the ball off and we're looking at the socket itself. There's a ring of cartilage or a washer around that socket called the labrum, and that is cartilage. At the very top of the labrum is where the biceps comes and attaches. Biceps 2, triceps 3, quadriceps 4. There's 2 parts of the biceps, and one of the bicep muscles sends its tendon. The muscle is going to grab onto the bone through the shoulder joint and attach to the top of that ring of cartilage. The top of the labrum is where the long head biceps tendon attaches. So a lot of times we'll be talking to the office to our patients, say you have a bicep problem. They say, no, I got a shoulder problem. That's because part of the biceps actually travels deep inside the shoulder and attaches to that ring of cartilage that can be damaged in that location. There's something called the joint capsule. The joint capsule are ligaments that surround the ball and socket joints. And the hip, they're very rigid and tight. And the shoulder, they're loosey-goosey. And that allows us to move that shoulder more easily. If they're super loose, you can dislocate the ball off the shoulder. If they're super tight, those capsule ligaments, and tighten down, it's called a frozen shoulder. We went ahead and talked about the biceps brachii, the long head of it, which is different than the short head attached to that ring of cartilage that we talked about. So overlying the ball and socket joint, overlying that rotator cuff happen to be solid structures. Those solid structures are what's called the acromion, or the top of the shoulder blade. The coracoid process, which is a finger that sticks off the front of the shoulder blade. And the clavicle or the collarbone up above. So those are rigid, bony structures that don't have any mobility to them. The ligaments themselves are also rigid attachments. Remember, ligaments connect bone to bone. So these rigid structures sit above some soft tissues and can be a culprit of pathology and pain and discomfort. And we'll talk about that a little bit more in detail here. There's something called the bursa. There's bursa sacs that occur all over the body. These are typically lubricated sacs of tissue that cut down on the friction between some of these solid structures that pass one another when we move our shoulder. They can cut down the friction, especially between the rotator cuff and the bones above and below. So how do we hurt our shoulder? We call that the mechanism of injury. There's traumatic ways, and how can that happen? You could fall down and go boom. You could catch something that's falling into your shoulder. You could throw something, you could pull something, you could lift something. All those forces can cause shoulder problems, okay? Or maybe repetitive activities do it, cleaning, painting, waxing a car, repetitive overhead sports like pitching. So you can have repetitive activities or a traumatic event, either of which can cause a shoulder condition. Now you could have a direct injury. Maybe someone takes a baseball bat and hits you in the shoulder. Or we can have an indirect injury where you fall onto an outstretched arm, your hand hits the ground, the forces of the ground travel up your hand, across your wrist, across the forearm, across the elbow, across the upper arm, that humerus, and injure the shoulder. So again, traumatic, repetitive, direct or indirect injuries can cause shoulder problems. So there's all types of sources of pain in the shoulder. A sprain, a strain, impingement, bursitis, tendonitis. You hear about spurs in the shoulder. We hear about dislocations, tearing, calcium deposits can occur. Arthritis can occur. So there's a whole slew of things that can cause these shoulder problems. I didn't even mention fractures on here. So a lot of sources of shoulder pain. What are some of the types of damage or the pathology or disease processes that we hear about in the shoulder? Well, we could talk about something called a strain. When we're talking about a strain, it's usually an injury to the muscle or the tendon, versus a sprain is an injury to a ligament. So when we sprain our ankle, we're actually injuring or tearing ligaments in the ankle. When we strain our quadriceps, that's a muscle. We're straining the muscle or the tendon of the quadriceps. We could actually have inflammation. So maybe we didn't have some incident occur, but over time, maybe with repetitive activities, we can have inflammation that can progress to worsening inflammation due to overstretching. We could partially tear those fibers. So again, these are fibers of ligament and tendon. And if we overstretch them, we can tear them partially or completely tear them all the way through. And that would be a tendon or ligament tear. We hear about the impingement, bursitis, tendonitis, spurs. These are terms that are thrown around by patients all the time, thrown around by doctors all the time. Let's get a better idea of what that really means. Impingement syndrome is a clinical diagnosis or pathology that occurs in the shoulder, okay? And I talked about this a little bit earlier. If you look at that top picture, you can see the bone of the humerus is a solid bony structure. Above is the acromion, top of the shoulder blade, clavicle, collarbone, and ligaments that connect those. Those are rigid structures. Now what we have is the bursa, or that soft lubricated sac, the tendon, which is a soft tissue as well, getting pinched with overhead activities. So now I raise my arm up in the air, I'm pinching the soft bursa of the soft tendon or impinging them between the humerus and those bony structures above. And that's impingement. And when we impinge those soft tissues, we get inflammation. And what is inflammation? Itis, laryngitis, tonsillitis, appendicitis. We get bursitis and tendonitis. And those go hand in hand, and those terms are interchangeable with impingement syndrome, okay? Now we talk about spurs. What are those? You can see in this one x-ray down below, there's a hole there. That hole is where that bursa and tendon exist. So now we have arthritis at the end of the collarbone. We have spurs from the arthritis that can be poking down, and now we've closed down that space further where the soft tissue of the bursa and rotator cuff travel. And now as we've closed down that surface, we raise our arm up in the air, there's even less leeway, more pinching of those spurs or hooks onto the bursa, onto the rotator cuff, causing inflammation, pain, and maybe digging holes in it and causing a tear. So that's what spurs and impingement are all about. Then we go on to the rotator cuff, one of the most common sources of pain in our 40s and upward, typically, okay? Usually kids, teenagers don't get rotator cuff problems for the most part. They get loose shoulder problems. They get labral or cartilage tear problems. As we get older, we get inflammation, rotator cuff, impingement, bursal problems. A lot of these diseases actually fit in different age brackets. And so with the rotator cuff, we get an inflammation of that rotator cuff. We have degeneration of the tendon over time. Just like our hair gets gray, our skin gets wrinkly, our tendon can deteriorate and weaken over time. And now we go ahead and cause impingement of it, beating up on it again and again. That degenerated, not so healthy young tissue anymore can cause a partial thickness tear, or maybe a full thickness tear where the tendon is torn off of the bone, or what I would call a massive tear where multiple of those 4 tendons are torn off the bone. If all 4 are torn and they're pulled all the way away from the ball, all the way towards the socket, we would term that a massive rotator cuff tear. So what's the problem with these tears? It's not so fun to have them in general, but the biggest issue is the healing does not occur. There are some tissues in the body that heal, others that don't. The problem with a rotator cuff is that tendon is attached to the bone. That tendon is attached to a muscle. The muscle is attached to the shoulder blade. That muscle wants to contract and pull the tendon towards the shoulder blade. So if that tendon, unfortunately, is pulled off the bone, it can't go back and reattach. It's being pulled towards the shoulder blade and neck. So it can't get back there, okay? So once the tendon's completely torn, now if there's a partial tear, then there's a thickness to that tendon. Maybe torn part of the way through and not all the way through. But if it's torn all the way through, now the muscle pulls it away and retracts it away from the bone. In addition, there's poor blood supply to that area of the body. And so it doesn't have good quality blood supply to be able to heal those torn tendons. The cuff is also bathed in joint fluid and it's lubricated, so it doesn't get to scab down. You think about, you get a cut and you're bleeding. You put pressure on it, you let it dry out, it scabs over. You keep putting alcohol or water on it, it's going to keep bleeding and bleeding and bleeding. And so we want to put pressure on it to get it stop bleeding. There's no way to put pressure on this area to get that lubricated tissue to dry out and adhere. That by itself doesn't sound so good, and it's not. But the biggest issue is that muscle that's connected to the tendon, that's no longer connected to the bone, can't get strong. As much as you work out in the gym, as much as you go to physical therapy, it's not attached anymore. So that muscle will atrophy and wither away and turn to fatty tissue over time. And the problem with that is if you wait too long to fix that tear, it might become all fatty, that muscle, and now it's no longer fixable. And what can happen is you get something called an irreparable or not repairable rotator cuff tear. So there's certain circumstances we choose not to fix a rotator cuff tear surgically. Not all needs fixing. But if we are in a patient circumstance where we believe as a surgeon it's in their best interest to fix it, we don't want to wait too long to get that done because it becomes not fixable at some point in time. Not all things can be fixed, unfortunately. You also hear about this other term called a shoulder dislocation. A shoulder dislocation is when that ball gets knocked off the socket. So we've got an x-ray on the top view there where you see that ball in all of our pictures I've shown so far is sitting right on the center of that socket. The x-ray below, you can see the ball's not touching the socket anymore. That's a shoulder dislocation. That typically happens when the ball gets wrenched out of the socket. That can happen out the front, out the bottom, or out the back. But typically it won't go out the top because that acromion and clavicle are sitting up there. You got to break through that to break it out. Fortunately, I've never seen that, hope never to. But the most common way is out the front, usually falling on an outstretched upper extremity, falling off a ladder, sliding to first base, okay? Wrenching the arm in this way pushes out the front. It could go out the back by being pushed this way. And I always think when I was training in Manhattan, I had a guy come into the ER. He was a bicycle messenger. He jammed on the brakes in traffic, had bilateral shoulder posterior dislocations. Horrible. But that happened because his arm was brought in this position, which is the posterior dislocation position, as opposed to this position is anterior, okay? And so those are just images that I think about to remind me which direction those positions force the shoulder out. Then there's something called a shoulder separation, different than a dislocation. This is where the collarbone or clavicle separates from the top of the shoulder blade or the acromion. So we have an intact AC joint or acromioclavicular joint in the top picture. The bottom x-ray, you can see there's a separation between the acromion or A and the C clavicle. The AC joint is separated. The ball and socket or glenohumeral joints is dislocated. And this is most commonly seen with guys checking into the boards in hockey. They get slammed to the boards. That force of the boards drives down the top of the shoulder blade, leaves the clavicle sitting up. And that's a shoulder separation as opposed to a dislocation. Then we hear about calcium deposits that occur in the shoulder. And this is an x-ray. That white fuzzy thing to the left of the shoulder is actually calcium deposit. We call this calcific tendonitis. So calcific calcium tendon, it's in the tendon that it deposits and sits, itis, inflammation. So we don't know why this happens, and it's a very, very painful thing. I mean, the two most painful things that I see in the shoulder, aside from after surgery or fracture, which you control with medicines, are an infected shoulder or calcific tendonitis. Very, very painful thing that comes into our office. And we don't know why it happens, comes out of nowhere. The good news is you don't have to get rid of the calcium necessarily to get rid of the pain. Then the shoulder arthritis. What is this? There's lots of different types of arthritis. You can have inflammatory arthritis, like a rheumatoid arthritis or a lupus. You can have arthritis secondary to a skin disease like psoriasis. You can have an infection in the shoulder causing arthritis. Rheumatoid arthritis is an inflammatory systemic problem that can affect joints. What I'm referring to specifically here is mechanical wear and tear. The beautiful thing about our bodies, we get cartilage that covers the surface of the ball and the surface of the socket. The bad thing is we get one set of that our whole life. And in 2024, we don't have a way to put it back. And so basically it's a mechanical wear and tear. It's kind of it's like you're losing the tread on your tire. When you hear about bone-on-bone arthritis, you've lost an entire white, smooth, shiny surface, and the bones are touching because that cartilage surface no longer resists. This could be due to trauma that occurred back in football season in high school. And over time, it wears out the shoulder, and now as an elderly person, that shoulder is worn away, typically due to a lot of miles on the shoulder. The good news is that it can be asymptomatic. Just because you have arthritis does not mean it hurts. And just because you have arthritis, if it doesn't hurt, there's no treatment necessary for it. I had plenty of people come in that get x-rays of both shoulders, and one side is arthritic, they have no pain. The other side has no arthritis, they're in miserable pain. Well, there's some other source of pain, and it's a good proof right there that just because you have an arthritic shoulder doesn't mean it's going to be symptomatic. You could also form arthritis at the end of the collarbone. So again, arthritis forms in joints, and the end of the collarbone joins to the top of the shoulder blade. That joint, the surfaces of the end of the collarbone and inside of that shoulder blade are covered in cartilage. There's cartilage that can wear out. That wears out, that's arthritis. And our body's very good at making bone. So one of the things we see in arthritis is spurs, or what we call medically osteophytes. Our body's great at making bone. You cut your skin, you get a scar. You cut your liver, you get a scar. You get your nerve, you get a scar. You break your bone, you get brand new bone. It's an amazing thing the body's able to do. Sometimes the body makes a mistake and says, oh, wait a second, I got a cartilage problem. I got arthritis. The cartilage is worn away. I got to put that back. No, don't know how to do that. I'll put some bone where it doesn't belong. I know how to do that. And so we get bony overgrowth or spurs. And again, we talked previously about the fact that these can be problematic for us. We talked about that ring of cartilage of the washer. Okay, there's a cartoon picture up above where the biceps is attaching to that ring of labrum. You could tear that ring off of the socket with the biceps or anywhere along that 360 circumference. The picture on the lower left-hand side there, that's actually an arthroscope or in-surgery image during the operation of the white surface of the cartilage on the ball, the white surface of the glenoid or the socket. That's the cartilage. That's not the bone. That's the surface cartilage is white. The bone is actually yellow behind it. So you can't see the bone. If you see the bone, that's not good. And then you can see that ring of cartilage and the biceps attaching. So this is a view of the patient on their side as opposed to the cartoon is right side up. And that's actually what I see at the time of surgery in a healthy shoulder joint, which I never want to see because I shouldn't be in the shoulder if it's a healthy shoulder. So what is the history? The history is where we learn about the patient. And there's lots of things we want to know. Sometimes the patient looks at this cross-side like, why are you asking us that? How is it relevant? I'm here for my shoulder. I'm asking about other things because they may be relevant and the patient might not know why, and that's okay. But we're going to ask about the medical history, the surgical history they've had, the medication list. Those may impact what we choose to treat them with. If they've had prior surgery on that shoulder, prior surgery on other joints for arthritis. We want to know what allergy they have because if we're going to inject the medication, if we're going to use topical patches or ointments, we're going to give them pills. We want to make sure it's not going to interact with other medications, that they're not allergic to it. How has the problem been addressed so far? If a patient comes to my office, already had treatment, why am I going to do the same thing some other doctor did? It didn't work already. Let's mix it up and try something different. There may be questions I said that you think are unrelated, but they may be relevant. So be patient with those doctors because they may have a lot of questions that you're questioning why they're asking them in the first place. But they're hopefully going to help us figure out not what's only going wrong, but how to make you feel better. We talked a little about symptoms of the shoulder, lots of symptoms, just like lots of different damage that can occur. We could have pain, looseness, stiffness, so a loose shoulder or a stiff shoulder. Popping, clicking, catching, weakness, numbness can occur. Pain at night is super common with shoulder problems. For whatever reason that we don't know, many of us believe it's the barometric pressure that can cause these changes and increase pain at night. Many times when we're sitting up, our shoulders kind of balance, sitting centered on that socket. When we lie on our back, we lie on our side, that ball slips off the socket, pulling on those inflamed tissues, putting pressure on the shoulder. If you raise your arm up overhead, well, what I just do, it's that impingement position. And so lying with that arm overhead on that side may cause impingement all night long. So nighttime is pretty tough for a lot of shoulder issues. Overhead activities may be more difficult than things below the shoulder. They might not be able to perform their job, hobbies, activities, daily living, sports, all things that impact our life. And these are a lot of complaints that come in with any shoulder pathology that I see. A really important piece of the puzzle for me as a diagnostician, as someone that's trying to figure out what's going wrong, is I got to prove the shoulder is the source of the symptoms. I had a lady come in the other day, actually yesterday, to the office with hip pain. Well, when I examined her, she had no orthopedic issue. She had pelvic pain or abdominal pain that is not in my realm of expertise. So I referred her back to her gynecologist or primary care physician to investigate further because that's out of my area of expertise. Well, lo and behold, one of the most common things people show up in the ER for is arm pain, secondary to having a heart attack. So you can have shoulder pain that's really cardiac etiology. All our nerves that operate our arms come from our neck, just like all the nerves that operate our legs come from our low back. So neck problems can cause arm and shoulder symptoms. If your diaphragm is irritated for some reason, it could cause shoulder symptoms. So not all shoulder pain is from the shoulder. And it's my job as your physician to evaluate and see if truly indeed it's a shoulder issue, or I got to treat your neck problem or send you to someone who knows is much smarter than I am to manage your heart. So we got to make sure we're dealing with shoulder pain and not dealing with the wrong thing altogether. The next thing we do is examine the patient. So again, we've taken a history, we've gathered information. When does it hurt? How does it hurt? How can we reproduce these symptoms? How is it interfering with your life? And now we put our hands on the patient. It's a physical examination. And I've got to touch the patient to evaluate their symptoms. Physical therapists and orthopedic doctors are known for causing pain in our offices. That's not the goal. We don't want to torture you guys. We want to figure out how do we reproduce those symptoms to better evaluate the source of the anatomy and pathology. Okay, and we're looking for pain, weakness. We're seeing if there's lack of or excessive motion. Is there nerve damage? Okay, one of the beautiful things, and I love about orthopedic surgery, I can get my hands on these things. The cardiologist cannot put their hand on the heart. We use a stethoscope to listen to the heart, but they can't put their fingers on it. We won't talk about the GI guys where they put their fingers, okay? But the reality is I can touch all these structures. I can feel that clavicle from the AC joint or sternum all the way across the collarbone to the AC joint that we talked about separating. I can go ahead and feel the spine of the scapula, the borders of the shoulder blade. I can feel them where those muscles attach. I can move that shoulder blade under my hand and see if it's winging up away from the thorax or the chest wall or the rib cage. There's bumps on the top of that ball where the rotator cuff attaches. There's a groove in the top of that ball where the bicep tendon sits. I can rotate that ball of the shoulder under my fingertips and feel those structures and see if pushing on them reproduces pain. So I love that part of ortho is that I could put my fingers on these structures and feel the bony anatomy moving under my fingertips to try and evaluate exactly the source of symptoms. Pretty cool stuff. So now we've done our history, gather information, put my hands on the patient, physically examine them, and now I've got an idea of what might be going on. Between the story, between the exam, I should have a great deal of data to support what I think is going on with that patient. The next thing to do is add imaging to it. And as an orthopedic surgeon, we get x-rays because we want to look at those bones. Most patients need it. It's rare that I won't get an x-ray. My feeling is the bone stops with me. If I don't get an x-ray, maybe no one else has. And that's important to me because although tumors of the musculoskeletal system are very, 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 very rare and almost never happen, okay? I've seen patients over the years. So they've seen their primary care doc. They've gone to therapy. They've been bounced back and forth. No one's ever gotten an x-ray. Boom, I get an x-ray. 6 months later, I find a tumor, okay? And so everyone, I think, in my office should definitely get an x-ray if they haven't had it before. And if they didn't get the right images, I may repeat better images with better techniques to really see the anatomy the way I want to see it. So x-rays are the bread and butter of orthopedic surgeons. You might get an ultrasound. An ultrasound is a way that's most famous looking at pregnant bellies and hearts, but we can look at soft tissue structures like tendons with our ultrasound. We could follow healing of tendons. We can better evaluate where to put injections in certain circumstances. MRIs seems to be the holy grail in the eyes of a lot of patients. Well, I need an MRI, I need an MRI, I need an MRI. No, you don't necessarily, because maybe we get an x-ray and gives us all the information we need because you actually have a bony arthritic problem that we don't need an MRI to prove, okay? So it's cheaper, it's right there in the office, and we get it done. MRI is really look at soft tissue structures, and it's not always necessary. Most commonly, it's gonna help out if we're not completely sure about the diagnosis, or in my case, for preoperative planning, to better evaluate the anatomy, the size of the tear, the location of the tear, how big it is, what's torn, where it needs to go. So that's where the MRI comes in for soft tissues. There's other circumstances where I'm looking at something very small and subtle. So in a young patient, an overhead athlete, pitcher, quarterback, they may have a labral tear, that ring of cartilage. That's something that's harder to see on a regular MRI, and to see things better, I might inject dye into their shoulder in the radiology department to fill up that space of the shoulder with dye, because it fills up spaces that are normal and then maybe fills up spaces that are abnormal and allows to differentiate between the normal and abnormal spaces. That is an MRI arthrogram, where we inject dye in the shoulder before getting the MRI, and that's not always necessary, but certain circumstances I might need that, especially in a post-surgical setting. So if I had someone who had surgery by another doctor or myself, and God forbid their shoulder's not doing well, their shoulder's never normal again after that surgery on the MRI, because now we have post-surgical changes. And differentiating post-surgical change from persistent or new trauma or damage may be hard without injecting dye in the shoulder. So we'll go ahead and do that very often. A CT scan is very commonly used for looking at brain and bellies, but when I'm looking at bone in greater detail, when I'm planning a joint replacement of the shoulder, I'm going to use a CAT scan to better evaluate the bony anatomy that's going to come into play with replacing a ball and socket joint. So these are all different types of images used for different things. They're not all necessary in every circumstance, but if you're questioning why a doctor is or is not ordering one, make sure you gather that data, that information, to learn for yourself why it's not indicated in this setting. And again, talking to your doctor, asking those questions is really going to be essential. Also, not all images are made equal. And I can't tell you how many patients come to my office that they want to save money, they were paying out of pocket, maybe their insurance wasn't covering something, and so they go to the cheapest place they could find to get their MRI done. We'll get, so what? Lo and behold, they come back and I can't see what I need to see. What does that mean? A Polaroid picture is very different than a high-def digital camera. An open MRI is not as good as a closed MRI in general. MRI is measured it's a magnet that makes our images, and it's measured in something called Tesla. And the higher the Tesla, the more powerful the magnet. So most open MRIs are 0.3 Tesla. Most closed IBGI MRIs are 1.5 Tesla. There are magnets out there are 3.0 Tesla. In most circumstances, we don't need the 3.0, but it's nice to have if you can get one. We are fortunate enough at IBGI to have multiple magnets that are open for 1.2 Tesla. So you want to get to a 1.2 Tesla magnet if you need an open MRI. When might that be necessary? If you're claustrophobic. To be put in a tube can be very scary. I'm not a guy that's claustrophobic in general. I got to tell you, I had a knee MRI years ago. I had my knee MRI. I said, pull me out, put me in head first because I want to see what these patients are freaking out about. I got to tell you, I'm not that big of a guy, and it was really freaky being inside that magnet. So I get it. My advice to you is if you've got to get an MRI, do it closed in a 1.5 Tesla magnet or higher. And if you're freaking out because it's claustrophobic, close your eyes. Don't open them. Close your eyes before you go into that magnet. Do not open them at all for a millisecond until you come out. You'll probably do okay. Because if you're not too big, you're probably not going to touch the walls of that magnet and be just fine. Most of these places have goggles, they have music to listen to, but just close those eyes. Do not open until you get out, and you should most likely do okay. Also, don't be frustrated by your surgeon because you walk in with that MRI you got from your primary care doctor and you're frustrated. Now your orthopedic surgeon wants an x-ray anyway, even though you have the MRI. The MRI is not the holy grail. Again, there's things you can see better on an x-ray than an MRI, so you might need both. So how do we treat these things? Okay, you come in with shoulder pain, we now figured out what the problem is, and typically we want to rest it. In certain circumstances, like a broken wrist or broken ankle, we'll put a cast on. There's really no way to cast that shoulder, even with a fracture. People get frustrated, like, wait a second, you're not putting a cast on me if I broke my shoulder? Well, no, I can't because it has to go around your neck. We're not going to strangle you with a cast and torture you that way. And so really the bread and butter way to immobilize a shoulder issue for whatever source of pathology, fracture, arthritis, otherwise, is a sling, okay? And we also just avoid things that hurt. Very simple. Apple a day keeps the doctor away. Hurts, don't move it, don't use it. Stop doing the activity that bothers you, okay? The downside of the sling is if it's not necessary, in most cases it's not, it can make you stiff. So I try very quickly to not immobilize joints if at all possible because we don't want to create a frozen shoulder or a stiff joint. So sling temporarily for acute injuries, post-surgical, post-fracture. Then we go on to modalities. Patients always say, doctor, ice or heat, ice or heat. And my answer is always whatever feels best. Feel better with heat, use it. Feel better with ice, use it. There's no magic there. But typically when we're treating post-surgical patients, especially in rehabbing them, ice is nice and motion is lotion, okay? So you want to warm up before the activity. So warm up before, cool down after. Warm up, warm moist heat, heating pad, hot shower, hot tub, loosen up prior to the activity, prior to the rehab, prior to the physical therapy, and afterwards inflamed, ice it down to decrease the inflammation for the acute injury. So again, warm up before, cool down after. And in terms of the amount of time, there's no magic to that. We also talked about maybe 20 minutes of time, 20 minutes on and off. The key is don't get frostbite. Because I can tell you, I've seen patients come in, put ice directly on the skin, think that more is better, and they come with frostbite on their skin and now have a new problem on their hands. So definitely these things can be overdone. Don't burn yourself and don't cause frostbite. Then we use medications. I mean, fortunately for me, I try and avoid medicines at all costs. Sometimes it's necessary though. I'm also one that prefers injections over pills because pills are systemic. They go in your stomach and all over your body. An injection is right where I need it to go, okay? But the medicines that we use are over the counter. Tylenol, ibuprofen, Aleve, typically pain relievers, anti-inflammatories, very safe. That's why they're over the counter medications. Can they be overdone? No question about it. You could destroy your liver if you take too much Tylenol, destroy your kidneys, too much anti-inflammatories, cause ulcers, you overdo it. So definitely don't want to do it, overdo it. Take it with food around meals is the best approach. We can prescribe anti-inflammatory medications. NSAIDs are non-steroidal anti-inflammatory medications. And so these are like an Aleve or ibuprofen, but maybe prescription strength. We might use something called the Medro dose pack, which is a prednisone, a strong steroid that's 1 week long with a tapering dose. You take one dose first day, a little bit less each day, and stop it over a week's time. Narcotics are typically something I really try and avoid. The only time I ever use them, post-fracture, post-surgery. Injections, this is my nemesis in the office. Patients have all types of myths they come in with, that it's bad for you, can only a certain amount of lifetime, destroy your bones, it's painful. No, 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 no. The truth is they help. They stay and work locally, they don't destroy your body. How many you get depends on where and why. In your Achilles tendon, the number in a lifetime, 0. One injection, you'll rupture the tendon. In an arthritic knee where someone's too sick or too old or doesn't want to have an operation, I'll inject. I've got a lady 102 years old in my office. She is not having a knee replacement, okay? I inject her every month. She comes in, loves her injection. I inject her once a month because who knows if she's going to be there the next month. So I will do that again and again and again in that certain situation. I don't think I'm doing the wrong thing. The cortisone doesn't hurt. The skill set of the doctor is what causes the pain. The needle hurts. And if it's done well, I've been told I give good needle, that it shouldn't really be that problematic. And these don't decrease, cause damage. They make you feel better. Physical therapy is to educate, to treat, to motivate patients that may be not so active, to give a home program. We want to rehab our bodies to improve the strength and health of the joint, to decrease symptoms. By decreasing inflammation, improving motion if we're stiff, increasing strength and the health of the tendon. This should not be torture, should not be miserable. We want to modify our activities. How do we do this? If it hurts, don't do it. If you got something up high, maybe raise the level of a chair on a computer. Use a ladder instead of reaching way overhead. You want to not reach behind the back and reach things out of the back seat. Use 2 hands. Use both sides. Typically overhead and behind the back are the worst. So if you can lower things, put them in front of the body, that's going to do less trauma to the shoulder. Who are we going to operate on? Not everyone's a good player, team player. You know, to get better, I want a good teammate. I'm the coach. If I don't get a good teammate that I can coach well and is going to follow the rules and be a good team player with a physical therapist and myself, I'd rather not operate on. So some patient who's compliant, they're going to behave, they're going to be a good teammate. They failed non-surgical ways to get better and remain symptomatic. That's who goes to surgery. And what do? We want to relieve their pain, get a full range of motion, manage all the pathology, reproduce close to normal anatomy. We want the repair to be strong, especially if they misbehave. Ideally, an outpatient surgery as opposed to putting them in the hospital, get them back to their activity, their hobby, their work, and give reproducible results again and again. What are we going to do? Under anesthesia, most go to sleep. Sometimes we'll give injections around the neck to numb up nerves so they go home without pain. Sometimes we'll inject inside the shoulder to numb things up. We used to use a pain pump. Those kind of fell out of favor. What are we addressing surgically? The bursitis, arthritis, the cartilage tears, the rotator cuff are all things we're going to fix. A decompression is cleaning out that bursa, removing that spur. So when you hear about a subacromial decompression, what we're doing is creating space for that bursa and cuff to exist and be happy. We're going to remove the end of the collarbone. When we deal with an arthritic joint, we can replace it, fuse it, or remove it. There's no way to replace or fuse this joint, so we remove the end of the collarbone, the end of the shoulder blade, keeping the ligaments intact so it's not a loose joint, and that's what we do in that setting. We might repair the cartilage that's torn off with the biceps with stitches and anchors. The rotator cuff is torn off the bone, we put it back down to the bone with stitches and anchors. That's what a rotator cuff repair is. When arthritic shoulder is present, what I say, cartilage cannot heal, cartilage cannot grow. So we've got to replace it with a metal and plastic joint. Just like we replace a hip or knee or ankle, we replace shoulders with metal and plastic. And this is what an x-ray of a shoulder replacement or a cartoon of that might look like. We can do surgery through big open cuts. Sometimes we'll do it through poke holes, depending on what we do. A shoulder replacement to put that big component in, I can't do it through poke holes. Got to do a big open incision to get that implant in. But most of the shoulder work that I do, aside from shoulders and replacements and fractures, is done through little poke holes. I make a poke hole, put a camera in, through our fiber optics, look on the screen, and have instruments that could work through those little poke holes to get the job done. So the trend in surgery is to go to minimally invasive procedures. The nice thing about that is there's less trauma to the normal tissues. To do a shoulder replacement, I got to cut through the skin, I got to go between the deltoid and the pec, and I got to cut through the rotator cuff to get inside. That means I've got to now repair the rotator cuff on the way out. That's a traumatic thing to a normal rotator cuff that wasn't torn before. That's how I get the job done. So now if there's jobs I can do without opening up the shoulder to fix a rotator cuff, which is what we did back in the day, big open cut, we've got to take part of the deltoid off the bone to get inside, repair the rotator cuff down, put the deltoid back on. Well, guess what? If the patient misbehaves and the deltoid comes off the bone, disaster, now they got a bigger problem than they had before. So the nice thing about doing the arthroscopy or shoulder scope through poke holes is that I can create less trauma to the normal tissues, less damage getting in and out. Because of that, there's less pain, there's smaller scars, which matters to a lot of people. I can see things better. Through an open incision in the front of the shoulder, I can only see through the front. I can't see the back side. okay? But through these pocals, I could take my camera out from the front pocal, put in the side pocal, put in the back pocal. I could get to all different places and see them better and up close, magnified in a way they can't through an open incision. So I could get to areas I couldn't potentially get to through the big open procedure. Not that their open procedures are bad, but they have their place, like in a fracture setting where I'm putting a big plate and screws on, or an arthritic setting where I'm replacing with a metal and plastic joint. But I love doing arthroscopy because I have less trauma. Now I've moved to outpatient surgery. The patients feel better after the operation sooner. The other advantage, as I said, less loss of motion. When I make a big open cut, there's bigger things to scar. If I make pocals, less scarring. So I can get their motion back better. As we talked about, motion is lotion, and the motion of the shoulder is significantly important to get our hand all different places, overhead, behind the back. So if I can improve their motion after surgery, a better thing to do. The outcome we've proved over time, many years, decades later of doing shoulder arthroscopy, the results are as good as the open surgeries that we did for certain pathology. This is outpatient surgery, the wave of the future. And one of the other things I love about it is when we can get to cure arthritis, which we're not close to doing and probably not my career or lifetime, the guys that do arthroscopy are going to put the joint replacement guys out of business because we're through our little pocals going to repair cartilage and not need to be replaced with metal and plastic joints anymore. So that's part of why I was excited about this part of orthopedics is beyond that cutting edge where we're going to do these minimally invasive things to solve big problems down the road. What are the variables? I'm going to kind of fly through this because I want to leave room for questions here. The variables are what kind of occupation and sport. You have a desk job, you're a laborer, steel worker. Very different in terms of the outcome and what we've got to do and how you're responding to non-surgical things. Pain control. Are you painful enough to work and play after surgery? Okay. Are you able to drive a car? Do you have to get in a car and commute? Are you on narcotic medicine? Are you in a brace after surgery? These are the variables that impact how quickly we get back to life, sports, and work after surgery or after an injury. There are variables related to the surgeon, their skill level, their intelligence, their experience, their inter-patient relations, the patient itself. Do they have a high pain tolerance? Do they not? Are they motivated? Are they compliant? What's the skill level of that therapist? Can they motivate the patient to do their home exercise? And the biology itself, is the tear 1 tendon, 3 tendons, 4 tendons? Is the tissue young and healthy or degenerative and beat up? These are all variables that impact the outcome. The constants typically after surgery, 1 to 2 weeks off due to pain control, brace up to 6 weeks most times. Therapy begins after surgery, or sometimes not until 6 weeks, lasts for many months. Driving most people to their dominant arm 8 to 12 weeks after an operation, if they're not a great driver, especially. Full activity 6 to 9 months after most shoulder surgery. How do we prevent this? Stretch. Yoga is better than weightlifting for these tendons in general because we're going to get strong. We need to stretch them out so we don't overstretch and tear them. Okay. Strengthen. High reps, low weights. Weights are good to maintain our fitness, to maintain the health of the shoulder. Cardiovascular fitness, essential. Core strengthening. So we're not lifting just with our shoulder and back, but our core. Use 2 hands close to the body. Use our legs when we lift. What do we avoid? Lifting behind the back, overhead, as I said. Lift close to the body, in front of the body. Prolonged overhead work, working through painful activities, all things we want to try and avoid. So lots of reasons to have shoulder pain. I touched upon a bunch of them, not all of them. Hopefully this was helpful. The good news is most shoulder problems do not require surgery to make them better. And there's a way to avoid surgery. I'm all for it. Sometimes it's the first most conservative thing to do. Your collarbone's broken, it's sticking out of the skin. The most conservative thing to do is go straight to surgery, okay? But the good news is most things don't need that. So free to contact us. They're gonna give you my office information. I take add-ons pretty much every day I'm in the office. We have a walk-in clinic at Illinois Bone and Joint in our Morton Grove office. I see patients every other in our walk-ins on Mondays. And really, we're not trying to hurt you, we're trying to make you feel better. Sometimes we're pretty busy and moving quick through our day. So if you feel we're moving too fast, talking too fast, like I may have done tonight, tell us to slow down so we can get your questions answered and make you feel comfortable with what's going on in your body, why you're hurting, and how we can make it better. So any questions? Hopefully I didn't go over. Are we good on time here, guys?
We're good. Yeah, we have 12 minutes.
Okay, good.
And a good number of questions. So thank you, Dr. Bresel. That was fabulous, really informative. Most of our questions do relate to that sort of the prevention part of it, but I'll start with a couple of the other ones first.
Okay.
George tells us it's been 2 years since his last visit for a checkup on his shoulder. Have there been a lot of advancements in the past 2 years, is his question. His main concerns from his last visit were primary osteoarthritis and idiopathic aseptic necrosis of his shoulder.
Okay, so what he's talking about is an injury to the blood supply of the bone. So it's avascular necrosis, or a without vascular blood supply to the bone, okay? Our bones are not that skeleton in the museum. Our bones are a living tissue that are changing from the day we're born to the day we die, okay? There's a blood supply to it. And for different reasons, that blood supply in different parts of our body, more common than others, can have an injury to that blood supply. Most times we don't know why it happens. Sometimes it's due to trauma. But if there's an injury to that blood supply, then that area of bone dies. And either it's going to heal like a fracture, and then you don't even know what happened because you might not even feel it going on, or it doesn't survive and the cartilage cap that's been supported by the bone can't be supported and collapses, you get arthritis, okay? So the answer to his question is, are there advancements in shoulder? Yes. Unfortunately, the management for an arthritic shoulder, whether it's due to avascular necrosis or some other reason, is medicines by mouth, medicines by injection, potentially physical therapy, topical medications, and then surgery. And so the surgery is replacing the damaged portion with metal and plastic, depending on the damage that's there.
Great, thank you very much. All right, Barbara says she's heard that when women hit menopause and their estrogen levels drop, it can cause frozen shoulder. And she wants to know, what can she do about shoulder pain without going on hormone replacement therapy?
Great question, mixed topics, okay? So menopause does not cause a frozen shoulder, period, end of story. When we are about 18 to 20 years old, that's the most bone we ever see in our body. And then we start losing our bone as time goes on, the rest of our life, okay? And then women hit this thing called menopause, where estrogen is protective for our bone and they drop off faster than men, which is why women are more commonly cursed with osteopenia or osteoporosis and need to have hormone replacement or vitamin D replacement. So yes, hormone replacement is important. Vitamin D is important. Sunlight is important to maintain your bone strength. Working out, upper body for your arms, walking for your legs to maintain bone strength. So yes, that's all good stuff. I'm not an endocrinologist, an OB-GYN, so I would defer to your OB-GYN in terms of the hormone replacement, okay? With that said, frozen shoulder is not necessarily age-related. It doesn't increase as we get older. It is more of an adult problem as opposed to a teenager youthful problem. It most commonly happens for no good reason. It can happen secondary to trauma, not big trauma at all, just lifting grocery bag. People with diabetes get it very, very commonly for no good reason at all, just because they have diabetes. So two different topics you're asking about. If you have shoulder pain, my advice is to come in and see us so we can figure out why you have that shoulder pain, but it's not due to weak bones or osteoporosis. Typically, a frozen shoulder is not correlated with that or associated with it.
Awesome, great answer, thank you. All right, James asks, does it make sense to do physical therapy, or should surgery be considered sooner rather than later? And it sounds like he had something happen. It says, well, retraction of a tendon happened eventually, thereby necessitating shoulder replacement. So maybe he's got a torn tendon, is my guess.
Yeah, so a lot of things being mixed up in that question.
Yeah.
Can you repeat one more time though, real quick?
He says, does it make any sense to do physical therapy, or should shoulder surgery be considered sooner than later?
I got it. So the answer is it depends.
Yeah.
Okay, it depends. There's some let's talk about a rotator cuff specifically, okay? And I may go over, I'm okay sticking around if you guys are okay sticking around answering questions. I have no problem with that unless you're hard stop. I'm okay with that too.
What would your hard stop be? I don't want to go too long.
I go to sleep at midnight. No, I mean, I'd stick around. I'd stick around another half hour if there's that many questions. I have no problem with that.
Thank you very much. All right.
So it's a complicated answer because it's a complicated issue. All right. If I've got a person that had no shoulder problems, okay, whatever age they're at, I don't care what age they're at, but typically we're going to talk about a rotator cuff. So this is not teens, 20s. This is typically 40s, late 30s till elderly, okay, whatever that means, because I'm feeling elderly some days. So if we have a healthy patient, healthy tissues, never had a shoulder problem, falls down, goes boom, tears the rotator cuff off the bone, okay, and we evaluate that by history, physical imaging studies, depending on the physical exam and history determines how quickly we get the MRI to evaluate that by imaging.
Yeah.
But now I've got an MRI with a muscle that's healthy and not atrophied. I've got a youthful patient, I don't care what age they are, and I got a brand new tear. I'm going to lean towards encouraging, not pushing or demanding, coaching that individual, that patient, that probably the best course of action, unless they're 90 or late 80s, is probably to fix that tendon surgically sooner than later, not emergently. They could wait months if they need to. I won't wait 6 months or a year, because the longer you wait, the more likely that tear can progress and get bigger without any trauma.
Right.
The longer you wait, that muscle may atrophy and turn to fat, the tissue, and become that irreparable tear that I spoke about. And so I'd like to get that individual in relatively soon for fixing, ideally. Okay. One scenario. Another scenario, maybe I had aches and pains, never a trauma. Maybe I had aches and pains in the shoulder and now some trauma. Doesn't matter to me which of those is. It is, okay? Aches and pains, go see the doctor. Trauma, go see the doctor. But now I've got someone in my office that I believe has a rotator cuff tear for whatever reason. I get an MRI of their shoulder for whatever reason. And I see not only do they have a big tear, maybe one or more tendons, but it's retracted past, ball socket, pulled past the socket. The muscles atrophy to fatty tissue. This is probably not something that's fixable surgically. That's a person I'm going to inject. I'm going to send a physical therapy. I'm not going to run a surgery. Why? Because they may have an irreparable tear, which is something that I might try and fix in someone in their 40s, but in someone in their 70s, 80s, 90s, I'm going to replace with a shoulder replacement, reverse shoulder operation.
Gotcha.
So again, I've kind of give two different scenarios, but my answer to your question is it depends.
Right.
Therapy is almost always very worthwhile, for sure, even preoperatively in certain circumstances if insurance will cover it. So I would never poo-poo or push away from a therapeutic solution, but some things are better off taken care of surgically depending on the circumstance.
Awesome. Awesome answer. Again, super. Thank you. And I appreciate the fact that you're going into the different scenarios, but of course it always depends. So thank you. All right. Jeff says he had rotator cuff surgery 8 years ago and still has arthritis. He says he knows when it's going to rain. Is this normal?
So a couple things. Number one, he said he had rotator cuff surgery, but he still has arthritis. Well, arthritis and rotator cuff surgery are two separate things.
Yeah.
They have nothing to do with one another. So does he have a painful shoulder that feels arthritic to him because of weather changes, post-surgery for a rotator cuff repair, or does he have an arthritic shoulder?
Right.
Either way, the reality is, unfortunately, much like many musculoskeletal issues are symptomatic at night, they're symptomatic with weather changes. And we can see how poor of a job these meteorologists do. Sorry if I'm offending any meteorologists on the call here, but I've got a trip planned to Florida this weekend to visit my son, and it's canceled because of the hurricane that hasn't formed yet that's supposed to hit landfall by Thursday when I'm flying. So I would wish all meteorologists had arthritis, because they can tell the weather changes, because unfortunately arthritis and musculoskeletal issues in general are more symptomatic with damp, rain, cold. And that's why a lot of people have arthritic joints, move to Arizona, and they don't have pain anymore in the wintertime. Because they got out of this crummy weather, this godforsaken Chicago winter. But the fact of the matter is we don't know why, but believe it's the barometric pressure changes that definitely have impact on musculoskeletal tissues. So the question I would pose to you is, do you really have arthritis, or do you have aches and pains post-surgery after a rotator cuff, and why is that still there? But it's not surprising that you have aches and pains with weather changes.
Awesome. Thank you. All right. Yeah, move to Arizona, Colorado, one of those Western states. Sure. Awesome. All righty. I know you talked about steroid injections. This person is asking for specifically for shoulder bursitis. Do you do steroid injections for shoulder bursitis?
Lots and lots and lots. So there's basically 5 places to inject the shoulder. Okay. I can inject the sternoclavicular joint. I can inject the AC joint. I can inject into the bursa. I can inject in the ball and socket joint. I can dissect in the bicipital groove. I can inject underneath the scapula, underneath the shoulder blade. So depending on where the problem is, determines where I put the medicine. And not only might I use the injections to make someone feel better, but I might use the injection for diagnostic purposes. So maybe this injection didn't help for a minute.
Gotcha.
This injection, this location helped much better. There's different types of cortisone to inject. Just because one doesn't work, maybe another one would. Some people have Tylenol, some people like Advil, and it works different for them. Same with the different types of cortisone. So yes, bursitis or inflammation at bursa, impingement, standard of care for me. I would much rather go to injection than a pill because it's acting locally and not systemically. So I use injections very frequently in that setting.
Okay, excellent. So you kind of went through what your assessments are. Then her last question would be, do you do them in your office or do they have to make a separate appointment?
I do it right then and there. It's amazing. I had a patient today, I'm ready to inject. Like, whoa, well, I'm not ready. I have to prepare for this. Would we have to go somewhere? No, you're not moving from where you're sitting. Right there's where it's happening. I'll be right back and we'll do it. So
Gotcha.
There's no big hullabaloo for it. In addition, there was a big push for ultrasound guided injections not that long ago. And a big piece of it, unfortunately, was increased reimbursement. We got paid more for doing those injections, significantly more with ultrasound. And I never kind of jumped on that bandwagon because I think most injections I can do, especially around the shoulder, without imaging. Is it bad to use imaging? No. Is it helpful? For sure. Is it necessary? Not necessarily. With my flow in my office, it would really slow me down. And because, as I said before, I could palpate these structures, I know exactly where to put that injection. Now, if I'm injecting a hip joint, having a spine injection, I would definitely use image guided either x-ray or ultrasound for those particular body parts. But in the shoulder or knee, I really don't need the imaging to do it. And I'll do it right there in the office, right when you're sitting there in a millisecond.
Awesome. Awesome. Thank you. All righty. Kevin says that he's in his mid-60s and he enjoys playing water volleyball many times a week. He's seen players get shoulder injuries over time. What can he do to prevent or mitigate shoulder injuries or excessive wear over time?
Staying in shape, that's the key. I mean, you're again involved in repetitive overactivities. So typically, a shoulder problem is common in that space. I mean, soccer players, they're injuring ankles and knees. Okay. Tennis players, pitchers, elbows and shoulders. Volleyball players, overhead shoulders. Okay. Football player, everything. All right. And so depending on your poison, it determines what more commonly you're going to injure. But I think the best thing for you to do is stay in shape. That means work out, stretch. As we get older, things get tighter. Overstretch, you get a loose shoulder. Well, that's not likely as we get older. Stiffness is our problem. And so if you really work on, yoga would be a great thing to do. Yoga and working out, really stretching, being healthy, cardiovascular fitness, core strength. So you're not only using the shoulder, but your core to hit that ball. Those are all things to do to help prevent.
Great. Awesome. Thank you. And I'm guessing, I don't know if water volleyball is standing or treading, but if you're treading, boy, you're getting some pretty good cardiovascular workout. If that's, I don't know that. I don't know that sport.
Usually standing.
Yeah. All right. Ricardo has a superior labral tear from 10 to 2. I'm guessing you know what that means. His only concern now is the clicking he hears when he reaches his arm over his head. When he swims, he often will hear the click. Will the repetitive motion of swimming cause any more issues or problems? He doesn't have any pain, but it does fatigue much more quickly than it used to. It says, thank you for the webinar. He appreciates all of your information.
Keep swimming, ignore the clicking. If it hurts, don't do it and see somebody. Okay. Yeah. My wrist click, my neck clicks, my back clicks, clicking doesn't bother me. You've got a diagnosis of a slap tear that can be asymptomatic with everyday life. If you keep swimming, could it tear further? It could. Are you going to stop swimming? Why? It could tear further. I mean, I tell people, like, you could sit in a wheelchair the rest of your life. Your knee arthritis might get worse. Are you going to stop walking? No. Walk, live your life, deal with the consequence later. If you're really adverse to consequences, well, give up that activity. But if that's the thing you love to do, swim, I would never tell you to give it up. It's not hurting. Go through it. Okay. If it hurts, then deal with it at some point in time. But I think, God forbid, you go out tomorrow and get hit by a car.
Right.
Swim all you can until you get hit by that car. We don't know what's going to happen tomorrow. So if you're not having any impediment to really functioning the way you want to, doing the activities you love to do, I'd never tell you to stop doing it, especially one that's, good for your mind, good for your heart, good for your lungs, good for your body. Keep doing it, but stay in shape. If it hurts bad enough, come see me. We'll deal with it and try and get you back in the pool.
Great. Thank you. That's perfect. Awesome. All righty. Mike was diagnosed with a rotator cuff impingement, received a cortisone shot, which relieved the symptoms for a few weeks, but his symptoms have since returned. His shoulder specialist recommended either PRP injection or a shoulder scope procedure. In your experience, how effective are platelet-rich plasma injections?
So I maybe missed because my phone buzzed.
Oh.
I'm
You
not
would
hearing that we got an MRI. I'm hearing that we had an injection therapy and have not got complete relief for our symptoms. And now the next step was either a PRP injection or having surgery. So
or
the
a
first-
shoulder scope procedure, correct?
Right.
Yep.
So the question I have is, have we had an MRI to prove there's a surgical condition?
Yeah,
Okay.
he was diagnosed with rotator cuff impingement. So yeah, that
Well,
maybe.
impingement, not a
No.
tear. And in my
Correct.
experience, most impingement is made better non-surgically. Okay.
Got it.
Not all, but the days of impingement surgery or bracectomy have gone by the wayside. I had a partner, I won't mention names, out in DuPage County years ago who did a zillion more shoulder operations than I did. He just did bracectomies, cleaning out the bursa, debriding, cleaning out, cleaning out, cleaning out. I was always trained to believe that wasn't really necessary. And if something's not being fixed, that you probably can get better non-surgically. Not 100% of the time, but in my experience, close to it. And so I would shy away from a impingement, debridement, subacromial decompression by itself, so much so that the government no longer pays for it.
Hmm.
Surgery we do has a code, it's a number.
Yep.
And the code for subacromial decompression is 29826. The government will no longer pay us for 29826 for a subacromial decompression unless there's something else we're doing in the shoulder in addition to it.
Gotcha.
My point is just emphasizing the fact that I'm on the side of the coin that believes impingement surgery by itself is rarely ever needed. And typically either there's something else going on that is not diagnosed yet surgical that needs surgery, or we just need more non-surgical treatment. Okay.
Got it.
That aside, the question also was about PRP.
Right.
PRP is not covered by insurance. Stem cells, amniotic fluid, adipose tissue, not covered by insurance. Okay. Again, we're looking for the holy grail. We're looking for something that's going to get tissues to heal that doesn't exist yet. Because there's not great data to support PRP use in general in orthopedics, insurance will not pay for it. You're going to pay out of pocket for it. What PRP is, we're draining blood. We're spinning it in a centrifuge, dividing the blood into red cells, white cells, and platelets. We're taking out the platelets, which heal our wounds, make scabs, healing potential. We're injecting that in different places in the body. Okay. And for my experience, it's fallen somewhat out of favor in the rotator cuff setting. There's certain areas we're doing it, like tennis elbow, Achilles tendonitis, patella tendonitis. Really good orthopedic data to support its use in those locations. Still, insurance won't cover it yet. So we have proven you have no definitive surgical problem, labral tear, arthritis, rotator cuff tear, that you've got an inflamed bursa. I'm not convinced you need surgery. If you want to throw the kitchen sink at it, willing to pay out of pocket, you have some expendable income, want to throw a PRP at it, you're not going to get hurt by it. You're not going to do damage by it. There's nothing wrong with it, but there's not good evidence to support it is going to help. With that said, there's something called the placebo effect.
Mm-hmm.
And so I've got a doctor in my podiatrist in my office that carries a magic wand in his pocket around the office. I'll tell you, I'm sure there's people where the magic wand works.
Yeah.
Because if you believe in the treatments,
Yep.
you may have a better outcome than if you don't believe in it. And that's to do with surgery, pills, injections, PRP, physical therapy. You got patients come and say, I don't believe in therapy. Well, it's not a religion. Okay? And so there's nothing to not believe in.
Yeah.
So the question is, if you don't believe in it, is it going to work? Probably not. If you have
Right.
faith that something is working in people that you want to try to avoid surgery and you don't need surgery, I would never discourage someone from getting PRP, and I give it once in a while. But after my conversation, most people shy away from it because I don't want to pay out of pocket for something that's not so predictable and not supported by the literature.
Got it. Thank you. I love your long explanations, and we still got 193 people on, so I'm going to keep asking questions until they start dropping off.
We don't have 193 questions, do we?
No, I don't think so.
I give
But I'm
one
sure a
answer.
whole
I
bunch
give
more
one
have come in. Yeah, no. We're good. We're good. So another Mike is asking what you recommend for strengthening, but we're not going to go into that tonight. But are there exercises that may contribute to impingement that you advise people not do?
Again, overhead behind the back.
That's
You
what I
know, you
figured.
want things, lower weights, high reps in front of the body below the shoulder level. That's the best thing to do. You know, I would go on YouTube and look up rotator cuff exercises. I mean, I'm sure IBGI Physical Therapy has them online, but if you look up rotator cuff exercises in someone reputable on the internet, you're going to find some good basic shoulder exercises to do.
Great. And that just answered Jeff's question as well. And we won't go into those on here because you can't find them so readily. All righty. Can you speak about nerve damage in the arm? I'm guessing related to the shoulder or going through the shoulder, but is that too broad a question?
Yeah, I mean, that's a super broad question. I mean, the nerves actually, come from your brain, spinal cord, branch of the neck, go down your arm. So there's lots and lots and lots and lots of issues related to the nerves, neurologic ones, traumatic ones, getting cut, dislocating your shoulder, injections being put in the wrong place, which is not typical for an orthopedic office. So and unfortunately, I mean, I could go on hours and hours talking about nerve problem, but yes, nerve issues do exist in the shoulder. Most of them do not need surgery. There's ones that do most commonly be carpal tunnel problems or cubital tunnel at the elbow. Fortunately, there's not that many shoulder issues that are nerve related. It can happen most commonly after dislocation. So you dislocate the ball off the socket, you're stretching those nerves, it can traumatize them. And that's probably, number one, very, 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 very uncommon with a shoulder dislocation, but probably the most common shoulder related nerve issue that I see.
Great, thank you. That's really helpful. And
one every several years at most.
Interesting. Okay, thank you very much. All righty, that person is left, so we're going to leave that out. Sorry, I haven't seen all these questions, so I'm reading through real quick to see.
Oh, go for it.
That's a little bit too personal. Sorry. How long? Pardon?
I'm an orthopedist, not a psychiatrist for these personal.
That's right. Exactly. All right. How long should recovery be after a reverse shoulder replacement?
Good question. So typically reverse shoulder, number one, a shoulder replacement will replace the ball with a metal ball, the socket with a plastic socket. Okay, that's done for an arthritic shoulder. A reverse shoulder replacement came into being because when someone has a torn rotator cuff, you cannot have a regular shoulder replacement because that rotator cuff holds the ball into the socket in place. If your rotator cuff is torn, that ball, the metal ball, now rides on the top of the plastic socket and wiggles it off. We call it a rocking horse glenoid. It rocks the plastic glenoid socket off. So years ago, a shoulder replacement was designed that could be put into a patient that has a torn rotator cuff, where we don't rely on the rotator cuff for this thing to do well and function. It's called a reverse shoulder. We actually go ahead and screw, instead of cementing a plastic socket on the socket, we screw a metal ball in the socket.
Got it.
Instead of putting a metal ball on the ball side, we put a plastic socket on a metal tray on the socket side to reverse the ball in the socket.
Yeah.
When we do a regular shoulder replacement with an intact rotator cuff that's not torn, we have to cut through the rotator cuff to get inside. I've got to repair the rotator cuff on the way out.
Right.
So really the hard part about a shoulder replacement recovery is you're recovering from an open, not an arthroscopic rotator cuff repair. So we've now got to protect the shoulder in a brace or sling for a period of time. We've got to go slow with rehabbing the shoulder to first get our motion back, then get our strength back. It takes about 6 months to recover from that, in my experience. A reverse shoulder replacement is done because we don't have a rotator cuff. Therefore, we don't have much to protect. We actually sometimes try and fix the front part of the rotator cuff during the reverse shoulder replacement. If it's not torn, the top part's the part that's usually torn. That's a part that we like to protect and get healed. So we may be more cautious post-operatively in a reverse shoulder replacement. We repair the subscapular front part of the cuff, as opposed to someone that has that part torn as well. Then there's no thing to really protect. So we may be a little more aggressive, start therapy a little bit earlier, use less therapy, do more on your own, have a little easier, faster recovery with what's a bigger, not as successful operation, because we don't have as much to protect.
Got it. Fascinating. Okay, that makes sense. So less than 6 months, possibly.
Essentially less than 6 months. And lo and behold, if we fix the front part of the rotator cuff and you misbehave and tear it, well, you got a reverse shoulder. So it matters less that it's torn. Now, it's better function if that doesn't tear. So I'm going to protect that longer. but typically you might have a little less time to recovery with a reverse than a regular shoulder replacement, but you're better off having a shoulder replacement, not reverse, if you can.
Got it. Yep. Great. Thank you very much. Okay. Bill has, it just says, is hyaluronic acid useful?
It is. What that is, some people call it a gel shot, okay? We all normally have lubrication within our joints. When you have damaged lubrication, not as good as it used to be. So that's a man-made lubricant we typically inject. It's a series of 5, sometimes a series of 3, sometimes an injection of 1, depending on who you're using, what product is being used. It's injected in joints that are arthritic, not for inflammation or rotator cuff tendonitis or rotator cuff tears, for arthritic joints all over the world, okay? In the United States, it's only FDA approved for the knee. So the only place in the United States your insurance will cover it is injecting it into the knee. With that said, if I've got someone with an arthritic shoulder and they're willing to pay out of pocket, fail pills, therapy, cortisone injections, I will have them do a gel shot into the shoulder if they're willing to pay out of pocket for it for an arthritic shoulder. Now, if you have an arthritic shoulder with a torn rotator cuff, we no longer have that contained space by the rotator cuff. It's blasted open. So there's no utility of putting the hyaluronic acid or gel shot in that, because we need that contained capsule to keep the gel inside the arthritic joint.
Got it. Got it. All right. Awesome. Thank you. Great answer. Okay. Let's see. James asks, would you have access to MRIs and x-rays that they've already taken through another IBJI doctor?
IBJI doctor, yes. Outside of IBJI doctor, no. No matter even if it's IBJI or not, I would leave the radiology department with the disc in hand. Because if you show up in the office and our computer system's not working for some reason, we can still see images. You come from outside, they say they're sending it to us, they never send it to us. They say we have access to Lutheran General, we don't. We're a private practice, not connected to their system. So every time you leave an image place, take the images with you. But if it's at IBJI, we should be able to see it.
Wonderful advice. Thank you. All righty.
I'm going to pause for 2 seconds.
Of course.
Because my battery's going to die. I want to plug in my computer. I'll be right back.
All right. Thank you. I'll keep reading questions. All righty.
All right, go ahead. Next question.
Well, while you're plugging in, I will tell you that Andrew says, after IBJI surgically repaired his rotator cuff 5 months ago, you were excellent at educating me on all the dynamics of the shoulder bones and muscles. Thank you. So I figured I'd throw that out there while you're plugging in. All righty. Joseph has arthritis in his left shoulder. If he needs a shoulder replacement or other surgery, he has a pacemaker in the area of his left shoulder. What do you have to do because of the pacemaker?
Nothing. We stay away from it. We stay away from it. The downside is that if his pacemaker is not MRI compatible, and it depending on how old it is and the system that was used, the company that was used, we might not be able to get an MRI. And so typically, before I do a shoulder replacement, I get a CAT scan to evaluate the bone anatomy, because I get instrumentation specific for that patient's anatomy to do the surgery. And I get an MRI to see if the rotator cuff is torn. Because if the rotator cuff is torn, they need a reverse. Right. If the rotator is not torn, then they get a regular shoulder replacement. I can't get an MRI if they have a pacemaker. And so I might get what's called a CT arthrogram, or a CAT scan with dye injected. And that's kind of the second best way to look for a rotator cuff tear, aside from an MRI. But the pacemaker position itself is typically placed far enough away from where our incision is going to be, and should not at all be impacted by the surgery.
Super. Thank you. Wonderful. All righty. Cynthia had frozen shoulder and had 40 PT sessions. She's so much better, but why is her shoulder still pinchy with certain movements? Will that ever go away?
Without examining her, it'd be tough for me to say.
Okay.
Maybe there's persistent stiffness that she's unaware of that may be causing some of the pinching. There could be something inflamed in the shoulder causing pinching. She could have arthritis, tendonitis, bursitis, labral tear. There's lots of things that can cause it. So if it's symptomatic enough that it's interfering with life and you don't want to live with it, come in and we'll take a look and figure out what that source of that pinching may be and how aggressive or non-aggressive we should be to manage it.
Great. Thank you very much. All right. Javier asks, is it true that getting a labrum repaired will make range of motion worse?
any surgery on any joints, if not managed well by physical therapy and a home exercise program in the postoperative period, will make a shoulder stiff. So it's not that labor repairs are going to cause a stiff shoulder and you're, kind of doomed to have a stiff shoulder because you had a labor repair. But typically, labor repairs in general are done because you've got a loose shoulder. We want to tighten it up a little bit. But you shouldn't be excessively tight after the surgery because you should be treated in physical therapy to regain your motion after the operation. But any surgery on any joint puts you at risk for a stiff joint, no matter where you are in the body.
Makes sense. Thank you. All right. James is a type 1 diabetic. Shots help, but the fallout just doesn't make it worth it. Are there other options?
Yeah, I mean, the challenge with diabetes is the corticosteroid elevates your sugar. The good news for a type 1 as opposed to a type 2 is they're on insulin, so more often than not, you can adjust your dose appropriately and jump on it because you're much more educated, much smarter, much more involved in your self-care usually and monitoring and managing your sugar levels. And so I would say in my personal experience, type 1s have had an easier time with the corticosteroids than the type 2s because the type 2s typically are not as well controlled many times and don't monitor it as well. So they may be more symptomatic with those spikes in the sugar from the cortisone. With that said, there's some people that still, with that said, and good appropriate management, still have a really rough time with the cortisone. So that's where I would go to oral medications, topical medications, go with the gel shots, the physical supplementation. Maybe that's the reason to go to PRP or stem cells to get some further treatment if you can afford to pay for those shots. But you're not doomed to have nothing done. It depends on, again, what the diagnosis is and how we go about managing it.
Great. Okay. Thank you. All right. Kathleen says she's heard that it's best to delay surgery 3 months or more after getting a cortisone injection that did not help due to issues with the tissue healing well. Is that true?
So back in the day, there was no correlation between time between cortisone and surgery, okay? In the recent past, there's been data to support that doing a corticosteroid injection within 3 months of the time of a joint replacement has increased the chance of getting a joint replacement infection.
Got it.
And that's a disaster.
Yeah.
And so we definitely don't want to give a cortisone injection in the 3-month window before a joint replacement. Now, the data I think is mostly for hips and knees. I don't know there's been equivalent data for shoulder replacements. With that said, I'm still abiding by it despite maybe not having the data for the shoulders. With that said, I would also say that too many injections too close together are potentially the issue for soft tissue damage. So as we talked about before, one injection by your Achilles tendon should never be done in your lifetime.
Right.
Okay. Cortisone injection in the shoulder, I try and space them out by about 3 months.
Okay.
That's the teaching. And they say total of 3 and that's it. Okay. Because the thought is too many too close together can cause some tissue damage and cause that tendon to tear. Why is that a problem? Now we've got a new problem, a tendon tear that I didn't have before.
Right.
Versus in the setting where I said inject again and again and again. Why? You don't have a new problem. You just have arthritis that needs a knee replacement. If you're not getting better with non-surgical things, you're not creating a new different problem. But with that said, I wouldn't do a maximum of 3 necessarily because the clock may start again. So I see someone I inject 3 times, I don't see him for 5 years. Do those 3 that you had 5 years ago really add to the 3 more that you do? We don't have that information. We don't have that data to know definitively.
Right. Okay. Thank you. Helpful. All right. Susan has a sore shoulder. Does lifting light weights help or harm it? Or do I need to refrain from the strength training for a certain period of time?
I would say that it depends on how you're lifting, what you're lifting. I would say that, again, therapy is lifting.
Right.
And so the order of events is not jumping into weights and therapy right away. The order is decrease inflammation. So maybe you can use topical medications, anti-inflammatory, do some light stretching. You can do some rubber bands as opposed to heavy weights, maybe cables as opposed to free weights. And so therapy is weightlifting ultimately, but you want to not lift through the painful thing. You want to also make sure you have the right form, you have the right equipment, that you're doing the right exercises. And so yes, lifting is good, but you want to do it in a controlled fashion and not just fight through the pain. You want to get the pain a little bit better before you start rehabbing it with the exercises. Great,
thank you. Awesome answer. All righty, we got 6 minutes and I'm letting you go. Okay, I'm just going to read it because it's long, but it seems interesting. You're after surgery and still have pain. Last MRI wasn't too bad, showed significant fluid, but not enough to do anything. Nothing else the doctor could do. Could fluid be causing the pain? And at what point should she go back to the doctor?
Well, the fluid typically is not the source of the pain. The fluid is there for some reason. And the question is, what is the fluid there for? Well, because of.
Right.
An excessive amount of fluid could definitely put pressure on the tissues, and you might want to drain that fluid out, maybe, if that's enough fluid to be drained. But the better question is, why is the fluid there? What's causing the fluid to be there? So the fluid itself is not the painful thing. What's causing the fluid to be there is probably the reason why you're having discomfort.
Awesome, thank you. All righty, Joyce has lupus and many joint pains, mostly weather driven. She's had shoulder pain for the last few years, off and on. She's had an MRI and was told the only way to fix her arthritic shoulder was a replacement. She's afraid because she's always taken tramadol over the years to help with lupus issues. She's afraid of pain management after surgery. She wondered if you would have, if you thought she would have a hard time because she's taken this stuff before.
Yeah, I mean, there's no question that if you're on chronic pain medication, it alters your system and makes it more challenging to control the pain. With that said, we use injections around the shoulder post-operatively or preoperatively for post-operative pain management. You could use topical things, you could use anti-inflammatories. So there's a lot of other methods and modalities to help control the pain. But I would tell you that if you've been treated by a pain management physician who's managing the chronic tramadol or narcotics, if that would be the case, I would definitely get into your primary, the pain management doctor to come up with a game plan, both pre, intra, and post-op, meaning you wean off the medicine for a period of time to decrease your tolerance so you have a better pain management experience afterward. So we adjust the medications, but I think that in your case, seeing a pain management specialist to help manage those pain medications is going to be a really important piece of the puzzle.
Great, thank you. All righty, Derek has a torn rotator cuff 50%. He coaches high school sports and is wondering how long it would take him to get back to coaching. He's heard 6 to 8 weeks. What does he suggest? What do you suggest for pain so that he can sleep at night?
I think there's a few questions in there.
Yeah, there's a bunch of them. Yeah, and I'm not sure if he's getting any
exactly what the question is. The first thing is, when you say 50%, is that 2 of the 4 tendons are torn?
Right.
Is it 50% mean one tendon is torn 50% of the way through? So I don't know what the answer to that is, but if it's not torn all the way through any one of those 4 tendons, that's a non-operative solution in my hands. Most times, not always. It's not torn off all the way. But to help you sleep, I mean, anti-inflammatory medications, icing, resting, corticosteroid injections, physical therapy are the ways to make your shoulder better, non-surgical.
Great, great. And it just depends how long it's going to take to heal, depending on how much 50% really is.
Torn tendon won't heal. Even if it's partially torn, it won't heal. But just because it doesn't heal doesn't mean it might not be asymptomatic. I've got people that come in with horrible arthritis due to a chronically torn rotator cuff. I inject them, I send them to therapy, their pain goes away. I didn't do anything to get rid of the damage. I didn't do anything to get rid of the pathology. I just made their symptoms go away. So you don't necessarily have to get rid of the damage to get rid of the symptoms.
Exactly. Awesome. Yep. Thank you. All righty. So Matthew says he's got shoulder pain under control with injections, but sometimes just a slight movement can cause unexpected sharp pain. And I'm guessing he's wondering, it was more like just a comment, but I'm guessing he's wondering, any idea what he can do to prevent that from happening?
Well, I mean, I would say, all the things we're talking about. I mean, the reality is, like with all musculoskeletal problems, this is not cancer. If you don't get it out, you're not here. Heart disease, you don't fix it, you're done.
Right.
This is the quality of life issue are the things that I take care of. How bad is it? How far are you willing to go to make it better? And what sacrifices and consequences are you willing to live with and deal with to accomplish that goal? Are you willing to adjust your activities? Are you willing to give up certain things? Are you willing to spend the time in rehab? Are you willing to recuperate for a period of time after surgery? So there's a lot of what ifs there, and the reality is it's a personal choice. I mean, I have people that would rather be in a wheelchair than walk.
Yeah.
People that no matter what, under any circumstance, don't want to live with 1 millisecond of pain so they have their knee replacement.
Yeah.
And neither of those choices, the wheelchair forever or the knee replacement, are wrong.
Exactly.
It depends on what your tolerance level is, what your expectations are. Are they realistic expectations? I mean, we're not going to be playing football in our 90s, most likely. You know, there's a lifetime to that sport.
Yep.
You know, so I think that you got to really be realistic about what makes sense and what you're willing to live with and not, you know, and realize that we're not in our teens and 20s. There's certain things that our body just won't do the way they did before. And can we play pickleball instead of singles tennis? You know, I mean, there's ways to stay active, stay in a sport that you love, be social, be physical, have fun, be competitive, but maybe you got to adjust what you're doing and realize that there's certain ways around it or not, and do whatever it takes to still play tennis. Maybe that's surgery.
And on that note, I think that's a great way to end it, is just, you know, you make decisions that work for you. And if you have problems with your shoulder, Dr. Mark Breslow is the guy to see, for sure. Thank you,
Well,
Dr.
guys,
Breslow.
I really appreciate it. It's been fun. I hope it was interesting and educational, and hopefully you don't need me, but if you do, please come see me.
Awesome. Thanks, Dr. Breslow, and thanks for the extra time as well. And thank you, everyone, for your questions and for sticking around. Have a great night, everybody.
Take care.
Take care.